and welcome back to another engaging episode of medical podcast series at MedSynapse. I am Dr. Harshada, your host, and today we are honored to have the esteemed presence of Dr. Srikamakshi. Doctor is a consultant head and neck oncologist and skull-based surgeon at Karkinos Healthcare, Hyderabad. And today our focus will be on an incredibly significant topic, management of head and neck tumors that invade skull base. Doctor has contributed to over 10 publications in the field of head and neck cancer, appearing in esteemed international and national journals. Notably, she's an enthusiastic researcher and firmly believes in the role of research in the progress of cancer treatment. So, we express our deep gratitude for having you with us, Dr. Srikamakshi.
Happy to be here too. It is nice for this opportunity to speak about a topic which is I'm quite close to my heart, which I'm quite passionate about, but which is not very often spoken about because it is not that common. But when it comes, it is can be quite a technical challenge.
Yes, doctor, thank you. Now we'll begin our session. Doctor, what are the common types of head and neck tumors that extend to the skull base?
So broadly, I have to first describe to you skull base can be classified into anterior skull base, middle skull base, posterior skull base, and lateral skull base. So in the purview of head and neck cancers which invade the skull base, we will basically be talking about anterior skull base, a little bit of posterior, a little bit of middle skull base, and lateral skull base. So it is tumors of the nasal cavity, the ethmoid sinus, and maxillary sinus, such as olfactory neuroblastoma, sinonasal undifferentiated carcinomas, adenocarcinomas, and in some cases, squamous cell carcinomas. These are the common histologies which tend to breach the skull base and extend beyond from the anterior aspect of the face. Now, when you speak about tumors of that breach the lateral skull base, it is mainly tumors of the temporal bone and temporal region. These are most commonly squamous cell carcinomas and to a smaller extent adenocystic carcinomas and adenocarcinomas. These most commonly arise in the ear, the mastoid region, and the other temporal parts of the temporal region, and they can invade the lateral skull base. So these are the primary tumors which we think of if we come across a tumor which is breaching the skull base either anteriorly or lateral.
Yes, doctor, and the diversity of these tumors underscores the importance of precise diagnosis. Doctor, can you elaborate on the diagnostic methods and imaging techniques used to accurately assess the extent of this head and neck tumors involving skull base?
Yes, as you rightly said, imaging is a cornerstone when it comes to the management of head and neck tumors which invade the skull base. When we talk about tumors that invade the anterior skull base, MRI, contrast enhanced MRI of the paranasal sinus in all cuts, axial cuts, coronal, and sagittal cuts. This is the most important for the evaluation of the tumor and its proximity or where it reaches the skull base. So generally, whenever we order a contrast enhanced MRI, it will be accompanied by a screening CT scan. And this CT scan will also give you details about the bone erosion or breach at the level of the skull base. In the MRI, the important things that you need to look at, you have so many sequences on an MRI. When you look at everything in toto, you will get information on perineural invasion, which is so important, where the tumors can travel along the nerves through the foramen ovale and extend intracranially. You get information about the hyperintensity that you're seeing. Is it actually tumor or is it secretions? Because you will see hyperintensity in the ethmoid sinus so close to the skull base where resection can be a technical challenge, and you really need to know whether it is tumor or is it just secretions which have gotten inspissated in the ethmoid sinus and is presenting like tumor. So for anterior skull base, MRI is the most important investigation. For tumors of the lateral skull base, the high resolution CT of the temporal bone, HRCT, this is the gold standard, where you get 1 millimeter cuts. You can see the temporal region and the lateral skull base through 1 millimeter cuts in all dimensions, axial, coronal, and sagittal. And you can get exact information on exactly how far anteriorly and medially is the tumor traveling. Has it reached the petrous apex? Has it reached the middle cranial fossa floor? So all this information you can get from a HRCT temporal bone. Other than that, of course, you will need a basic endoscopic evaluation. You can check for whether the contralateral nasal cavity is involved, whether the nasopharynx is involved. This will help you in planning your surgery beforehand.
Yes, doctor, thank you for your detailed explanation. And yes, there has to be a systematic approach to determine the extent of tumor's involvement accurately. So, doctor, moving ahead, how do you tailor treatment plans when considering factors like tumor size, location, and proximity to critical structures?
See, so although almost all of these tumors, which I discussed, mentioned previously, will require surgery in their treatment plan, either initially or later. Luckily, most of them are either chemo or radiosensitive. For example, olfactory neuroblastomas and sinonasal undifferentiated carcinomas are chemosensitive, while squamous cell carcinomas are radiosensitive. Why I am telling you this is many times we will come across really large volume tumors which have breached a large section of the skull base. So we will know that if you're going to approach it by surgery up front, it's going to involve a huge resection, a huge portion of dura. Sometimes you will actually have to resect brain if you contemplate surgery up front. So what is generally done is we will, if it is a chemosensitive tumor like the SNUCs, we will first give neoadjuvant chemotherapy. It will melt it to a large extent. So when you do surgery after chemotherapy, the extent of resection will be reduced, and so will be correspondingly the postoperative morbidity. Similarly, for tumor pathologies like squamous cell carcinoma, they are extremely radiosensitive. So for a similar situation, we will first give neoadjuvant radiotherapy, sometimes neoadjuvant chemoradiotherapy to shrink the tumor, and surgery will be staged so that the extent of resection can be minimized. So once that is done, and we feel that we have achieved an optimal tumor volume, we then assess the tumor status critically at that point, the location, the proximity to critical structures, so that we can plan surgery next.
Yes, now, doctor, can you discuss on the role of surgical interventions in removing head and neck tumors that involve skull base, and what consideration are taken into account to optimize surgical outcomes?
So, surgery for the skull base. Let me first speak about anterior skull base. Surgery for tumors that breach the anterior skull base. There are two approaches broadly. You can either go by an endoscopic approach or you go by the more conventional open approach. Okay. So, why did this endoscopic approach come up at all? So, endoscopic approach, now it's become so famous. Now, even neurosurgeons, so many neurosurgeons have trained themselves in an endoscopic approach to a skull base tumor, simply because you will do away with so much of the morbidity that is associated with an open approach. When you talk about an open approach, you will remove a portion of the skull bone, you have to handle the brain. All of that, no matter how well the surgery is done, will have its own set of side effects. So the endoscopic approach was developed in an attempt to do away with many of those side effects. And however, having said that, you cannot do an endoscopic approach for every patient. You need to identify the right patient. You need to first look at the pre-op endoscopy, look at the pre-operative MRI, and you decide whether this entire tumor can be removed endoscopically through the nose. So when you identify such a patient, generally these surgeries cannot be done by a single surgeon. It will involve two surgeons, and in many cases, one of them will be a neurosurgeon. Because if you're going to have to resect dura or intracranial tissue, you need to have a neurosurgeon on board. So generally, it will be a combination of a head and neck surgeon and neurosurgeon. The two doctors will stand on either side of the patient, because then you will have four hands. It's called a four-handed technique. Of the four hands, one will always have to be holding the endoscope and camera, and one of the hands will always have to be suctioning, because it's such a small space. You need to keep clearing whatever can be cleared. So you will have only two more hands to actually perform the surgery. So what is done as the first step is we first go in. I mentioned that we see the contralateral nose pre-op. Why? So that you can harvest the nasoseptal flap or the Hadad flap as it is popularly known from the contralateral side. That is the first step. Why you do that? That is used to provide a buttress at the end of surgery. This vascularized flap is extremely important for the post-operative healing and the prevention of complications. Once you do that, the septal bone and cartilage is removed. Once you do that, both the nasal cavities collapse into a single common cavity. And that is a huge field. You have so much of operating space. And then you go in, you do the surgery, do the resection, resect the dura if you can from below. And once that is done, you will reconstruct with most commonly facial lata from the thigh, fat, sometimes septal cartilage, and you finally overlay with this nasoseptal flap that you had harvested at the beginning. Okay, so this is an ideal endoscopic resection for a skull base case. However, in many cases, this may not be possible. So sometimes what we will do is we will do this approach. We will release whatever is possible endoscopically from below. Then the neurosurgeon will come from top. We will put a bicoronal incision, remove the frontal bone, and you will address the tumor from above. Why do we do all this? Because so many papers have shown that negative margins is one of the most important factors which prevents tumor recurrence, specifically for these tumors which breach the skull base. So that is done. Sometimes an endoscopic approach may not be possible at all because the tumor may be involving the adjacent maxillary sinus and the maxillary bone. So in that case, we don't try an endoscopic approach. We go and open directly for a sort of a maxillectomy, an extended maxillectomy by something called the Weber-Ferguson incision. We do the maxillectomy from below and the neurosurgeon comes in from above to complete the tumor resection. For lateral skull base tumor, like I said, most of them, they are temporal bone squamous cell carcinomas. It will begin with a regular modified radical mastoidectomy. It will begin with a mastoidectomy and we will proceed to follow the tumor. So that surgery is also quite complex. It will involve the use of the microscope because as you keep proceeding along the middle skull base floor, you will see a lot of critical structures. You first have to handle the facial nerve. You try to preserve it if possible. If it is invaded by the tumor, you have to resect it. Sometimes you can reconstruct it later with a greater auricular nerve graft. Then you proceed along the middle skull base floor. These are called fish approaches, described by a surgeon by name Hugo Fish. They're types 1, 2, and 3, depending on how anteromedially the tumor went to petrous apex. It can go even as far as medially as the eustachian tube orifice and the internal carotid artery. So this is the lateral skull base resection, and then you reconstruct it many times with the temporalis muscle itself, which is adjacent. Sometimes the temporalis muscle itself will need to be resected as part of the surgery, and then you may have to put in a free flap or a PMMC or flap from elsewhere. Yeah, so these can be quite complex surgeries, but when you choose the patient right and you give the neoadjuvant treatment wherever possible, and then you go in and you achieve negative margins, there is nothing like that. You will be contributing to improve the patient's disease-free survival and overall survival.
And doctor, can you share your insights into the potential complications and functional outcomes associated with its treatment?
Yeah, so like I described, it's quite a long and complex surgery. So, since we're talking about skull base, obviously, when the reconstruction of the skull base you could not achieve a watertight reconstruction. There is always the risk of CSF leak. And since these tumors are extending from the nasal cavity and the oral cavity, which are clean contaminated sites, there is a very high chance of ascending infection. When you have ascending infection, it's going to lead to meningitis. It can be quite serious. Many of these, so all these patients, whenever we do skull base resection, we will generally advise strict bed rest for 5 days. They should not lift weights. They are not allowed to strain even when passing stool. We give them laxatives to ease the pass of stools. We try to make sure they are totally infection free and dust free so that they don't sneeze. So a lot of precautions have to be taken in the first 5 days so that reconstruction we have done actually seals. And of course, like I said, we need to prevent. So this same effort also prevents ascending infection. So we have to make sure that appropriate perioperative antibiotics are given, drugs which will cross the blood-brain barrier. So perioperative antibiotics, proper post-operative antibiotics, and if you have done an open approach, you need to make sure the wound is clean. The eye may have been addressed. You need to give eye ointment, eye drops. If there has been brain handling, you may need to give steroids, mannitol. So surgery is not the end. Surgery is just the beginning. There is a long post-operative road for these patients. So this is when the endoscopic approach comes in. When you have managed to do everything endoscopically, once you've crossed the first 5 days and the patient is okay, you can generally plan to discharge them after that. Whereas for an open approach, patients may need to stay in for 2 weeks or even longer until we are sure that they are out of any risk of infection, and so far and so forth. And of course, if we have resected the olfactory nerve, olfactory bulb, patient may have anosmia later on. If we have resected the facial nerve, they will have facial palsy. If we had gone to the jugular bulb, we have handled the cranial nerves 9, 10, 11, 12, the corresponding paresis or palsy may be there. So it all depends upon what was the volume of the tumor, what were the critical structures involved pre-op, and what could we preserve and what did we have to sacrifice for the purpose of R0 resection during surgery.
So, doctor, what long-term follow-up and surveillance measures do you implement to monitor the status of head and neck tumors that have reached the skull base and ensure early detection of potential recurrence?
See, by and large, we will have to follow the same post-operative, uh, protocol that we follow for other head and neck tumors. We will be doing a close clinical examination. Generally, the protocol that is followed for any head and neck tumor patient who's undergone surgery or radiation is that we will call them for a follow-up every month in the first 6 months, every 2 months in the next 6 months, then every 3 months for the following 3 years, and every 6 months in the fourth and fifth year, and after that is an annual follow-up. So in these follow-ups, what we look for first is for an anterior nasal cavity, oral cavity, they will come with very significant nasal discharge or nasal bleed or nasal block, or difficulty swallowing and things like that, difficulty chewing. And for the ear, they will complain of ear pain and they'll complain of ear discharge, blood in the ear. Specifically to see if it has recurred in the skull base, headache. First common symptom is headache. They will complain of dizziness. They will have pain around the face, very unexplained, very significant sort of pain around the eye. If it has traveled up to the cavernous sinus, which is not very far, they may have involvement of the ophthalmic, the V2, V3, the maxillary nerve, the mandibular nerve, sometimes the third, fourth, sixth nerves, which will affect your extraocular movements. And of course, if we had managed to preserve the facial nerve during surgery, and if now the facial nerve has been involved during the recurrence, they will present with frank facial palsies. They can present with dizziness if the vestibular regions have been preserved and now they have been affected. So generally, pain and any presentation of a cranial nerve palsy would be the first warning sign of a skull base involvement of a head and neck.
Thank you, doctor, for the comprehensive explanation. And yes, multidisciplinary approach is required for comprehensive care to patients. So now that brings us to the end of today's session. So thank you, doctor, for your time and sharing your expertise on this topic. It was a great pleasure to have you here with us. And a huge thank you to our audience for tuning in. We hope you found this session informative and insightful. Remember to stay connected with MedSynapse for the latest advancements and expert knowledge. I'll see you soon again. Bye bye.